Thank you very much, Tony. In 2011, when I stopped work at Prince Charles, I thought life was going to be easy, but this man made sure it wasn't. As he said, I'm a radiologist, and my talk's going to be very different to Ralph's because I'm going to talk about imaging and its role in asbestos-related diseases. And you all know that asbestos-related diseases are basically caused by the inhalation of asbestos fibres. Now, this little thing is actually an asbestos body. I don't seem to have much. But asbestos fibres are smaller, and you can see red cells there. So these things are quite small, and they're inhaled into the lungs, and they travel out in the airways into the periphery of the lungs, where they're toxic, and they cause damage and scarring and resulting in disease which damages the lungs. The interesting thing about it is that asbestos-related disease also occurs outside the lungs, in the lining of the lungs, and how it gets there we're not quite sure, because there's a gap between the lung and the pleura on the inside of the chest wall, but somehow the asbestos bodies either get across in lymphatics or go through the pleural space, irritate the pleura and give rise to disease there. So what I'd like to do is to talk a little bit about the methods that as a radiologist we use to make these diagnoses, and then the manifestations of these diseases that we can see radiologically. Now, the manifestations are predominantly benign processes. A lot of people feel that if they have a disease due to asbestos exposure, it might be fatal or it's universally terrible. Not the case at all. Most people live very good and useful lives and can live very long lives after being diagnosed with asbestos-related conditions. Unfortunately, there are some very nasty ones as well, but most of them, in most cases, the process is fairly slowly progressive and people do very well. Now, the benign pleural disease consists of several different things. Pleural plaques, which I'll show you later, which can be calcified and non-calcified. Pleural effusions, which is fluid on the lung, fluid in the pleural space, and diffuse pleural thickening, which is an interesting process, which is also quite a significant process. Benign lung disease, that's within the lung itself, consists of pleuroparenchymal bands, which we'll see in some pictures, which are very common, and a condition called rounded atelectasis, which is part of what's called sometimes trapped lung, which represents large areas of fibrosis, and the condition that most people are concerned about, and that is asbestosis. The malignant conditions are mesothelioma, which is primary carcinoma of the pleura, and lung carcinoma, which is primary carcinoma of the lung. Now, these conditions take a while to develop in most patients. You all know that there are quite a lot of lag times, and this is just a representation of that. It's like radiation, like the thing that I was exposed to, in that it doesn't manifest straight away, and it might be 20 years later that this disease and this process manifests itself. So we always have to remember that when we're looking at things. Now, first of all, I'd like to talk about the basic techniques, because I don't know how much people really understand about what is the role of the chest radiograph and of CT scans. But the chest radiograph is the basic examination that we use to detect asbestos-related disease, and it's been around a long time, and it's very helpful. Now, in this condition, the patient stands in front of a detector system. The X-ray tube's over here on the right. Here's the patient here. This is the radiographer, and an X-ray beam goes from the tube through the patient and is picked up on a set of detectors. When I was, most of my life in radiology, we used X-ray film to record the images. Now, of course, time's moved on and they're digital images detected on a set of digital detectors. But the X-ray beam passes through the patient, and as it goes through the patient, it's blocked by various things. If things are a high atomic number or they're very dense, they block the X-rays. So coming out of the other side of the patient, there's a modified X-ray beam which reflects the pathology that the beams pass through. And then we turn that into an X-ray image using the either film or digital techniques. Now, this is what a normal chest X-ray looks like. On this side over here, on the left-hand side, is the posterior anterior chest X-ray, which was what we were doing to that patient before. And this view on the right side here is a lateral view, is a lateral view. Now, as you can see, The white thing in the middle is the heart. The heart absorbs a lot of X-rays. Behind it is the spine, which is calcified. It absorbs more. Then the ribs are these white, the ribs running laterally are white. They absorb in between, and then in between those there's the dark areas, which are lung. And inside the lung you can see little vessels. Now the problem with this chest radiograph is that the X-ray beam has to go from the back to the front, and it's going through a lot of different things. So the density of all these things represents all these things it's gone through. So it's a composite density. So what we do is we do a lateral view, and the two of them together help us to understand things. But there are areas in the chest X-ray that you can't see very well. If you look at down here on that film there, it's behind the diaphragms here. We don't see it. There are areas in against the spine here which are very hard to see on the PA film. So although it's a very useful examination, it has limitations. Now, this is basically just the anatomy. You can see that we've got the lungs on both sides, the ribs, the mediastinum in the centre, and the spine. But what's interesting is that the lungs sit in the thorax, and on the outside of the lungs, I'm having a bit of trouble with this pointer, there's a thin line of what is called visceral pleura, and it coats the surface of the lung. I always think of it as like Glad wrap stuck on the surface of the lung. Then there's a cavity, a very small cavity, and there's a similar lining of pleura on the inside surface of the chest wall. And the chest wall has got the ribs and muscles and fascia, and there's another layer there, and in between them there's a thin pleural space. That normally has about 15 mils of fluid in it, which acts as a lubricant. So when you breathe in, the lungs can slide over the chest wall, and this is where fluid accumulates. Now, pleural plaques, when they form on the outside layer of the pleura, not the one on the lung surface, the parietal pleura. Now, on the lung is divided into lobes with these fissures, and the visceral pleura on the surface of the lung goes into those fissures, right into them, whereas the parietal pleura just coats the inside of the chest wall. Now, of course, the other technique, which has become more and more important in recent years, is CT scanning, and this is a totally different technique. In a CT scan, the patient goes into a machine, into a tunnel. There's an X-ray tube on one side. There's a large set of detectors on the other. Here they are here. The X-ray beams go through the patient. The whole gantry, which is the X-ray tube and detectors, rotate round the patient while the patient moves through the machine. These machines can scan a whole chest now very quickly in a couple of seconds. So we get a big volume of data, and the images are mathematically reconstructed images. Now we get an image fundamentally which looks like this, which looks like a cross-section, very different to a chest radiograph, and it has thickness. It has only a thickness of 1 millimetre to, say, 10 millimetres. So it's a very different type of presentation with the lungs on the outside, the pleura running around the edge, the heart in the middle, and the arteries and veins and things running out into the lungs. Now, again, the pleura, you can see exactly the same. The pleura around the chest is those two coloured lines round there with a thin layer in between. Here's where fluid accumulates. Now, this is a normal CT scan of the chest, and the first thing you notice is that you can't see everything on a single image. Because there's such a broad range of densities we can see on a CT scan, we have to look at it under different circumstances to see things. The one on the left here is presented to look at soft tissues, and you can see the greyness of the soft tissue of the muscle in the chest. The lungs are completely black. Inside the lungs, there's some vessels showing. This patient has had X-ray dye, which makes the aorta stand out bright, but the lungs are all black, and we can't really see anything that's going on in the lungs apart from a few vessels. But when we window it such that we can see the lungs, we make the rest of it white. But here now we can see the detail in the lungs. What do we see in the lungs? Well, these things are vessels. They're the pulmonary arteries and the pulmonary veins. So the vessels that take blood, unoxygenated blood to the lungs, and the veins that bring it back, and the airways. Now, you can't see many airways in this. You can see the central ones, But the peripheral ones are small and they're hard to see because they're filled with air and they've got a thin wall. But what I'd like you to notice is if you look at the periphery of the lung round here, it's very sharp and clean. The vessels are very small because the vessels start here and they go out that way and then they go back. So the small ones are in the periphery. So we don't see much in the peripheral 5 millimetres of lung. It's normally clear. Now, we'd like to do some special types of CT scans for asbestos-related diseases. One of them is high-resolution scanning. Now, high-resolution scanning doesn't necessarily mean that it's better than non-high-resolution scanning. It means that it's more appropriate for looking at fine lung details. And you can see that here. This is the one on the right. This one here on your right is a thick slice, and you can see how fuzzy this disease down here is. And if you look at the fissures in the lungs, this is the visceral pleura. You can see it beautifully there. Here it's quite fuzzy. But we get an effect of linearity here with vessels. They're longer, so we can distinguish what little dot, instead of seeing a small round dot, vessels look longer. So it's easier to detect small nodules. They stand out more from the vessels, and there are other advantages here, but for most asbestos work, we like high resolution work, and we like to do it in deep inspiration, a good inspiratory effort. And the reason for that is that if you breathe out, the air exits the lungs collapse and they're denser. So you can get artificially, you can see all this stuff here on the expiration stand, which looks like disease. You think you've got something nasty. When you take a nice breath, it goes away. So it's very important we get good inspiratory films. Now, to go on to dealing with these various conditions that I mentioned, and we'll start with pleural plaques. Now, pleural plaques are fibrous areas of thickening which occur on the pleura, on the chest wall, not on the lung. They're very rare on the lung itself. And you can see them on a chest radiograph as these whiter areas here. Because they absorb more radiation, they're a little bit denser than lungs, and you see one side clearly and the other side fades into the chest wall. But you can see they're difficult to see sometimes. They're difficult to see in against the spine because we can't see that so well. So if we take a CT scan, it's very easy to see the plaques. Here they are, here's one here. These are only small plaques here, here, here. They stick out and they're easy to see because of the way the image is taken. These are plaques that are calcified. You can see down here this white stuff here. You can see the rib, and then in front of it there's a white line. That is lying in a pleural plaque. You can see a plaque up here, left, other plaques, but the white line is calcification. Looks just like a rib, but it's just on the inside of the chest. Calcification again. So plaques calcify with time. Now, pleural plaques are benign. They usually don't cause problems, and they're regarded more as a marker of asbestos exposure than a measure of asbestos exposure. So you can get pleural plaques with very small exposure. You'd be surprised at the number of people in the community who have a few pleural plaques who don't even remember how they got them. And many people live with that and don't even know about it. But they can get very thick. If you look at this plaque here, you can see it's over 1 centimetre thick and heavily calcified. So they can be big, chunky things that cover a lot of the chest wall. And when they do that, we wonder how much some of these things might impair lung function. The other thing that we see that's important in asbestos exposure is pleural fluid. Now, sometimes fluid accumulates in that pleural space and we can see it. In asbestos-related conditions, we get often what we call an inflammatory effusion. It's not, if you look at it, it's blood-stained, it's a little bit thicker, it's full of cells, and people can get pain and they can get fever with it, just like an infection. It can be inflammatory. Not always, but they can. Whereas the pleural fluid we commonly see in something like heart failure is thin, almost water-like, or like beer maybe, perhaps. But it's thin and it doesn't cause the problems. This pleural fluid can cause significant problems. Now, on a chest radiograph, the pleural fluid drops to the bottom here because the patient is standing up. On a CT scan, it goes to the back. So here is pleural fluid here, running around the inside of the chest. There is also some calcified plaque here in the same place. There's plaques over here, but this is pleural fluid. It tracks around the lung. In that pleural space, there's a negative pressure, and as I say, there's only 15 millimetres of fluid. There's no air. Pleural fluid in asbestos exposure can resolve, or it can go ahead to form diffuse pleural thickening. Because it's an inflammatory process, it thickens the pleura, and the two layers of pleura get stuck together like glue. So suddenly you have this thick pleura, not pleural plaques. It involves both visceral and parietal pleura that are stuck together. So when you breathe in, the lung can't slide over the chest wall. That's the first thing. The second thing is the lung can't move and expand and contract under the visceral pleural thickening. So you get changes which occur in the lung. These changes are not usually regarded as asbestosis, but they can cause significant respiratory impairment. Now, on a chest X-ray, it's difficult. You can see the angles, the sharp angles we saw in a normal one weren't here, and there's thickening down here. But when we get a CT scan, you can see tracking around here, just like the pleural fluid, there's a layer of thick pleura, but it's a little bit denser. And this can go right round the lung, and it can be very extensive. I've seen plenty of patients in which it has covered the surface of both lungs. Now, what this thick pleura does is it stops the lungs expanding and it causes changes. Now, those changes can be... Oh, sorry, I'm going the wrong way here. Those changes can represent what we call pleuroparenchymal bands. This big thick thing here is a fibrous band extending into the lung from thick pleura down here. We can't see it because of the way we windowed things. These are smaller ones up here running parallel, and some that run inwards. And what happens is the visceral pleura on the surface of the lung gets involved with fibrosis, and the fibrosis extends in along the septa between the lobes of the lung. The lung gets stiff, it can't expand, and it thickens and becomes fibrotic. Now, it can be very bad. This is a really bad case. You can see this patient's got calcified plaque here. They've got diffuse pleural thickening, which is about 8 millimetres thick. They've got all these big bands extending into the lower lobes. Here's the fissure, which is depressed. So these lower lobes are severely diseased by this pleuroparenchymal bands and rounded atelectasis, which is the other process. This process over here is, you can see something against the pleura, which is a large lump, which has got strands running into here, and it's known as it's known as rounded atelectasis. Here it is again in a soft tissue window. It's this lump here. They look like cancers. Now, this patient's got pleural thickening running around here. This is fat, pleural thickening, fluid, and a large area of rounded atelectasis with these comet tails which go into the lung, and they contract. Because they're fibrotic, they contract the lung. And I've seen the lower lobes with things like this virtually non-existent. They're completely contracted and not functioning at all. So rounded atelectasis is a benign process. It can remain very stable for years. It can look like cancer, and it causes problems by causing lung contraction in association with diffuse pleural thickening. Now, the other benign lung process is asbestosis, and I'll spend a little bit more time on this because this is what most people worry about. Now, asbestosis in general, again, is a relatively benign process. Most people I see with asbestosis live good, healthy lives, and they can live a normal life expectancy. But it can progress and it can kill them. But usually it's very slow. Now, what happens is that those little asbestos fibres go out to the periphery of the lung, where they get stuck in what's called the respiratory bronchioles, which are small airways in the periphery of the lung. And there they set up a toxic reaction. The body fights them. They get coated with iron, but they cause fibrosis. That fibrosis extends into the adjacent lung, but the process occurs in the periphery. Now, these films are taken upside down, and I'll explain that in a minute, but it helps us to do that because the lung falls away and we see the lung bases better. And this process is most common in the lung bases posteriorly. Now, you can see in the periphery of these lungs that there's small dots, some little lines, and some sort of reticular type patterns. This is asbestosis. This is established but relatively mild disease, but it's well established. This is not query asbestosis, this is asbestosis. And you can see that it only involves the periphery of the lung. Now this again is another case of asbestosis, and you can see the same sorts of things. This time we've got a linear band up here on the left side parallel to the surface of the lung, and we've got these densities here, which we call ground glass densities, purely a descriptive term, not a pathological term. It means that you can see it, but you can see the lung through it. It often represents fibrosis, but it can represent other things. And we see lines. Now, some of these are vessels. These vessels we wouldn't normally see out this far. We see them out that far because the periphery of the lung is starting to collapse and sucking them in against the chest wall. This is the plaque here, and this process here is asbestosis. Now, sometimes the changes in the lung form these linear, crescentic-shaped things which parallel the surface of the lung. And here they are here, running around like that. This is said to be relatively specific for asbestosis, but like everything in chest radiology, it's not specific. Most of the things in the lungs are not entirely specific. And I'd like to stress the fact that radiology taken in isolation is not the same as radiology taken in conjunction with good clinical stories, because some of the changes we see here are not specific for asbestosis. Some of these asbestosis changes, they can occur in idiopathic pulmonary fibrosis and connective tissue diseases and drug-induced changes. So we have to really correlate these changes with the clinical story. But these things here occur more in asbestosis, these lines, than in any other interstitial lung condition that I know of. Again, we can see this is a coronal view, and we can see these thickened lines, which are thickened interlobular septa. They're very much like the lines that we saw with diffuse pleural thickening, but they occur in the absence of diffuse pleural thickening. They occur from a different process. In diffuse pleural thickening, they occur because we've got fibrosis of the pleura on the surface of the lung, with that fibrosis extending in along septa. These occur from inside the lung out. The fibres in the periphery of the lung there, they cause a reaction which starts around the airways, gets around the lobule, extends around the tissues around the lobule and causes these lines. And they are part of asbestosis. Now, why do we do the films upside down or do them prone? It's important because when you lie on your back, and this is the one on the left there, I hope there's some more thumbs. When you lie on your back here, you can see that there are changes in the posterior lung. Ground glass density lying here. Now, what happens when someone's lying like that is that as they breathe in, the chest expands anteriorly. The back of the lung doesn't move much. So this doesn't expand very much. This expands a lot more. And also you've got the weight of the blood, which is, say, 20 centimetres, coming down here. So there's a head of pressure in the vessels there and lack of movement, and you tend to get accumulation of some collapse. So the lung alveoli don't aerate, and you get changes which look very much like interstitial lung disease. And the only way we can really prove whether they are or not is to roll the patient over. If we roll the patient over so they're lying on the tummy, this is the same patient, you can see these changes have gone away. So as a radiologist, and if there's any question of asbestos-related disease in the lung, we always want a prone examination. Now, sometimes that's difficult. If people are short of breath, they don't like lying on their tummy and having the scan. They find it a bit difficult, but it's worth persisting because it's very helpful. Apart from making sure we don't misinterpret these changes, the lung drops away a little bit and it expands a little bit better, and you can see the periphery of the lung better, so you can also pick up early disease better if you've got prone examinations. So it's an essential part of the examination. The radiation dose in doing these extra examinations today is very small. To do a CAT scan like this with a series of prone films on a patient might be 2 to 3 times your natural radiation from living in Brisbane for a year. So you might get about 3 years worth of natural radiation, which is pretty small. We can do a scan with about 1 year's worth, but because we're looking often for very fine structures, and it's very important to pick up these very early changes, well, not in that one, very early changes, we really need that. Now, this is a patient who's got more advanced disease, and you can see here immediately that there are different changes here. Here's fibrosis with honeycomb cyst formation. You've heard about that. When the fibrosis gets severe, it damages the lung, destroys the architecture, and it comes to look like a piece of honeycomb, completely destroyed. And you can see it in those areas up the top there. And then more advanced lung disease. You can see now that we've got lots of areas of disease in the lungs. So this is relatively advanced asbestosis. We see bands, you can see honeycombing. We can see airways down here. There's some little airways which are pulled apart, a thing called traction bronchiectasis. Because this is fibrosis, when it contracts, it pulls the airways apart and widens them. And that's called traction bronchiectasis. It's a feature of this. Now, just to finish off briefly, because my time's almost up, with the two malignant conditions, mesothelioma. Mesothelioma is a cancer of the pleura. It usually occurs at various stages after exposure. And it usually presents with weight loss or pain or other symptoms like that. The chest radiograph usually shows a pleural effusion. And this patient's got a pleural effusion down the bottom here. Sometimes you see pleural plaques and sometimes pleural thickening. But a pleural effusion is really the important sign. On a CT scan, you can see that this disease is thickened areas of pleura. This big, thick nodules, and all this disease, and here's the spleen, the liver. This is the lower chest, full up with tumour, and this tumour encases the lung. This is typical mesothelioma, a very advanced process. Starts in the pleura, starts in the parietal pleura, not the visceral pleura, the parietal pleura on the surface of the lung. And lung cancer, which is carcinoma of the lung, but lung cancer starts in the lung. It's a tumour of the lung. Mesothelioma is a tumour of the pleura, although when these tumours get advanced, of course, they involve everything. So this is a lung cancer, and you can see this is not it. The pleura comes around here. This is in the lung. So that's all I really have time to say for today. So thank you very much. I'm very happy as to answer any questions.
Thank you very much, Doctor, for that very informative talk. It's a very complex issue, asbestos disease, so many different manifestations of asbestos exposure in the lungs, and it all starts with radiology. Do we have any questions of Denise and Dawn? Maybe Dawn first?
Yep. Yeah, thank you, Doctor. Can you tell me, would a change of scenery make any difference to somebody with pleural plaque? In other words, from a drier, outer suburban situation to a coastal situation?
I think there's no evidence to suggest that that's the case. Pleural plaques tend to steadily progress, particularly with calcification, but very slowly from once we first see them. They don't usually get much bigger over time. They're a remarkably benign process, and I don't know of anything that modifies or changes their progression.
Thank you.
Thank you, Doctor. Do you have any information that you could give on the tracking and monitoring of disease in peritoneal mesothelioma?
In peritoneal. Well, first of all, just to say about the monitoring of disease in the chest, as I said, plaques, there's no great need to monitor plaques because they don't lead. Plaques don't turn into mesothelioma. Mesothelioma develops de novo often in association with plaques, although 50% of patients don't have plaque. With tumour, and I assume you were speaking about mesothelioma, which it affects the linings as well as affecting the pleura. It can affect the lining, the peritoneal lining in the abdomen. It can do that two ways. One, it can invade from the chest and go through the diaphragm into the abdomen, or it can even be start off separately in the abdomen as a separate process. It's more difficult to see it in the, or to assess its extent. You can imagine in the abdomen that the peritoneal cavity is very complex. It's not like the chest, which is a simpler structure. We can see it in and out of little crevices between loops of bowel. The only way that I think would be with CT scanning, but again, it's not as accurate as it would be in the chest. But again, I think radiation doses in CT scanning are pretty low today, and if you're monitoring something that's a life-threatening disease, I think there's no real issue about it. You do it if you need it. And I think CT scanning would be... PET scanning is used, but it does, mesothelioma does uptake FDG, but only moderately so. And I think you wouldn't want to be doing PET scans regularly. They're much higher radiation dose. I think CT would be the only real option.
Over here. Yeah, Dr. Slaughter, I know we're talking about mesothelioma and asbestosis and things like that, but why have we got the reading of black lung imaging so wrong? Is it the same kind of process? And why have we... It's been noted that we've read it wrong, and someone in the States is saying this is how you do it.
That's true. This again is a very large issue, but I'll give you my picture on it very briefly. I think that there was a thought that black lung had disappeared. There's no doubt. And the process in Queensland, there was a monitoring process in Queensland in place using chest radiographs and lung function testing. Unfortunately, because no cases have been seen for a long time, I think that was neglected. And it wasn't done as well as it could have been. Cases weren't stored properly. They weren't always looked at by the appropriate people. And some of the doctors also working in the industry had never seen a case. Things got slack. So there's no doubt there's been an error. There is a new process in place now which will be much, much better. I think the problem is not as bad as sometimes the press makes out. The last time I saw it, there were only still about 20 patients in Queensland who'd been diagnosed with black lung, and most of them, the disease was mild. Again, it takes about 20 years of underground mining. But with the other process that is mining has changed. You know, they never had this long wall mining years ago when the early program was set up. People actually are exposed to a lot more dust today. I mean, although levels, there's an attempt to keep levels low, and it's obviously very difficult. You know, wearing that apparatus in a hot aspect of down an underground mine is very difficult. So I think that any preventable disease should be prevented. It's a tragedy that anyone has silicosis or coal workers pneumoconiosis, because this is a preventable disease, and we must take every step we can, just like every step to prevent it. The trouble with asbestosis is it was a long time before we realised. I think with black lung, took our foot off the pedal. That was the problem, and it got away from us. Mining industry changed. There was a lot more dust, and people had really just forgotten about it.
Is it the same process though, like the CT scan, that it's picked up?
Yes, today we use chest radiographs for screening. The reason for that is that this disease occurs in remote places. All the mining towns, CAT scanners with qualified radiologists who look at occupational lung disease are not available often. So I think we all believe it's appropriate to use a chest X-ray as a screening test. And to report it using the ILO classification, which is an epidemiologic classification that we can use to assess PRODES. We were not doing that in Australia very satisfactorily. The problem is that I don't believe that there's any problem with the people in Australia. They're just as well qualified and just as capable of detecting this disease as in the United States. In fact, the problems in the United States are greater because they don't have a compulsory screening process. It's voluntary in most places, and most miners, if they've got disease, sometimes they don't want it to be known about because it pulls them out of the underground work, they lose their bonuses, so they don't present, which is a tragedy. Here there is a compulsory process, and it can be picked up early by the screening test. If something is picked up, if you have a chest radiograph that is more than a 1-0 on the ILO classification, that's very early disease, you will have a CT scan, and the CT scan is highly accurate. But the chest radiograph at that level has a lot of false positives and has some false negatives. But if it gets more than that, it gets more accurate. So I think the new process in place now should be pretty good. I don't think we'll see a vast number now that there's much more awareness. I think mine dust levels will be legislated to be lower, and there'll be a lot more interest in the whole process. There are some people who have severe disease, but most of the patients I've seen of that, I suppose there's 25 now, maybe I've seen half of those, had relatively mild disease, fortunately.
One final question. Barney Sanders, I think there. Is it Rod Towerton? Rod? Okay. One quick question from Rod. Maybe a quick one from Barney? Okay. Thanks.
Yeah, Doctor, you were talking earlier about pleural plaques and the difference between CT scans and just an ordinary X-ray. In your opinion, how often do you think CT scans should be done to monitor those pleural plaques up against just an ordinary X-ray?
I don't think you have to monitor pleural plaques closely at all. As I said, pleural plaques themselves don't progress to cancer.
Okay.
They're a benign process and they stay benign, but people with pleural plaques have a higher chance of getting mesothelioma because the pleural plaques show that they've had a significant asbestos exposure.
Okay.
Monitoring, doing regular X-rays, CT scans or chest X-rays to detect mesothelioma has not been helpful. So to find a mesothelioma in an asymptomatic patient is rare. So I don't think I would want to monitor pleural plaques. Anything, 2 years would be the closest. Maybe you could even go longer if you had to, because it's not really going to help you very much, and you don't really need a CT scan. If you've got any symptoms at all or any problems, that's when you have a scan.
Yeah, as in once I've been diagnosed with pleural plaques and had a scan.
Yes.
That's the reason I was asking.
Are you asymptomatic now?
Yes.
Well, if you get mesothelioma, and hopefully you don't, you will get symptoms. If you just do a CT scan now, your chances of detecting very early mesothelioma is remote. It's not like breast screening where you see a tiny little thing. Most cases of mesothelioma we see present with pleural fluid, and the pleural fluid causes symptoms. So the patients immediately get symptoms. Sometimes we can't even find the mesothelioma tumour. It's so small it's hidden. So doing regular screening is not like breast screening where you hope to pick it up small. It doesn't work that way. So I think you can relax a little bit. It depends really on what your exposure is. If it's a high exposure, you're at greater risk. But if you have any symptoms at all, you certainly need to see someone and get imaged.
Yep. Thank you very much.
Yeah, just to revisit the question the lady asked before, are you saying that asbestos affects other organs in the body apart from the stomach as well?
Yes, it affects the pleura and the lungs, and it affects the membrane in the abdomen. That's the peritoneal membrane, because that's very similar to the pleura. And you can get mesothelioma starting in the abdomen all by itself, uncommon. Most of the cases I've seen in the abdomen have been chest mesothelioma that's gone through the diaphragm into the abdomen, but it can start in the lining of the abdominal cavity.
Then does it affect other organs, kidneys, liver, etc.?
Only as a secondary response. It's a cancer and it will metastasise, but you won't start off getting a mesothelioma in your kidney.
Thank you, Doctor. Just on that, Barney, though, to follow on with that question, there is evidence linking asbestos exposure with kidney cancer, esophageal cancer, and particularly laryngeal cancer, not mesothelioma, but cancers of those organs. So for workers' compensation purposes, we have had those cases accepted in highly exposed people, but that's not mesothelioma, it's cancers of those organs. Yeah.